A very good morning, ladies and gentlemen. We warmly welcome you all to the first technical session of the 15th International Research Conference of General Sir John Kotelawala, Defence University.
Now you're here with us in the medicine session based on the theme of research, development and innovation in the healthcare sector to ensure sustainable economic growth. An apt theme, I must say, given in the present circumstances.
Ladies and gentlemen, so this session will be chaired by Senior Professor Mirani Weerasooriya and Dr. Janaka Munasinghe.
Ladies and gentlemen, we now have the honor of introducing the two distinguished chairpersons of this session.
Professor Mirani Weerasooriya is a Senior Professor of Parasitology at the Faculty of Medicine, General Sir John Kotelawala, Defence University. She was also the Dean of the Faculty of Allied Health Sciences at KDU. She previously served at the University of Ruhuna as the Senior Professor of Parasitology and also as the Dean of the Faculty of Graduate Studies prior to her retirement. During her long career, which spans for over 3 decades as a university academic, in addition to her teaching and administrative commitments, she was also instrumental in establishing the Pholidosis Research Training Service Unit at the University of Ruhuna. She is a GRC Award winner of the Sri Lanka Association for the Advancement of Science and an orator for the Sri Lanka Medical Association, Gold Medical Association, and also for the Kandy Society of Medicine. Moreover, she has also published several articles widely gaining national and international recognition in the subject. She is currently serving as the MPhil and PhD program coordinator for KDU.
Dr. Janaka Munasinghe is a graduate of Faculty of Medicine of the University of Colombo. He holds an MD in medicine from the same university. He is currently a senior lecturer of the Faculty of Medicine of General Sir John Kotelawala Defence University and a senior consultant physician of the University Hospital, KDU. He has served in the Ministry of Health as a clinical pharmacologist of the Medical Research Institute and consultant physician of the National Hospital of Sri Lanka. He is also an honorary senior lecturer of the University of Colombo and an examiner for the final MBBS examination of universities Colombo, Sri Jayawardenepura and Ragama, and an examiner for the MD Medicine examination of PGIM. His research interests are in therapeutic drug monitoring and monitoring of adverse drug reactions. He has received the prestigious Presidential Award for Research in 2004 and 2018.
So now, ladies and gentlemen, with great pleasure, I cordially invite Senior Professor Mirani Weerasooriya and Dr. Janaka Munasinghe to commence the first technical session of our IRC.
Good morning to all of you. Let me first welcome all of you for this first technical session in medicine. And this session, we have lined up a guest lecture by an eminent, very senior neurologist and a professor of neurology from Western Health, Australia. That is Professor Tissa Wijeratne. And he has kindly agreed to have a discussion session of 5 minutes after his presentation. Then after that, we have 3 oral presentations. And I would like to give certain instructions to the oral presenters that the time for presentation is 10 minutes. At the end of 8 minutes, there will be 1 tap on the bell. And at the end of 10 minutes, there will be 2 taps. So please, I expect all of you to stick to time. 10 minutes for each presentation and 5 minutes discussion time after each presentation. Now, let me invite Dr. Professor Tissa Wijeratne on stage. And Dr. Pandulata, I would like to make the introduction about him.
The chairpersons, Senior Professor Mirani Weerasooriya and Dr. Janaka Munasinghe, Dean Professor Namal Vijayasinghe, and senior professors, track chair and secretary, and distinguished gathering of medical colleagues. It's an absolute pleasure to introduce yet another brilliant Sri Lankan colleague par excellence in the global context to deliver our special guest lecture. My friend, and also he happens to be a compatriot of Professor Namal Vijayasinghe. He's Professor Tissa Wijeratne, senior neurologist, Professor and Director of Academic Medicine and Head of the Department of Neurology and Stroke at Western Health, Victoria, Australia. It's one of the fastest growing state-of-the-art units in Australia. He was an excellent fellow product of the University of Peradeniya, swiftly progressing through his MD, PhD, and 4 fellowships. His academic track record is truly phenomenal. 256 papers, more than 75,000 citations, 128 orations or presentations, more than 3,000 media segments. This is why he's functioning as the chair of International Working Group for Young Neurologists and Trainees, Special Interest Group for Headaches and Migraine of the World Federation of Neurorehabilitation, Chair Public Awareness and Advocacy Committee of the same. He is also the first Sri Lankan neurologist to be elected as a member of the International Committee for American Academy of Neurology, and is a recipient of the prestigious Donald M. Palatucci Advocacy Leadership Award, Ted Munsat Award of World Federation of Neurology, Stroke Champion Award, NSF, Priscilla Kincaid Smith Award, AMA 2019, A.B. Barker Teacher Recognition Award by AN in 2020. This has masterminded the birth of the Australian and New Zealand Headache Society and the birth of James Lance Peter Goudsby Annual Migraine Oration and Symposium. And he has also founded David Marsden Memorial Annual Movement Disorder Symposium and successfully advocated for free membership of the Movement Disorder Society for neurologists from middle and low income countries such as ourselves, and for free membership for all medical students worldwide to the American Academy of Neurology. I think this is from a trainer's perspective, this is a very important aspect. This has supervised as a trainer for Royal Australasian College of Physicians and trained more than 1,800 physicians through the RACP online supervisor training throughout the pandemic. And he has launched the world's first global migraine Bill of Rights at Genoa in 2019. He led the 2019-22 World Brain Day campaign with a global impact, and he's the first Asian or Australian nominee to be the Secretary General, World Federation of Neurology, and the current president of Asian Regional Consortium for Headache. But what's most impressive is that Tissa, despite all these commitments, remains humble and is simple, and his passion to help Sri Lanka is truly phenomenal. When I invited him to KDU IRC 2022 in the midst of fuel crisis and long queues, etc., he still had no hesitation to extend his fullest support to us. So thank you, Tissa, for that wonderful gesture, and we look forward to hearing your special lecture today.
Thank you very much, Pandula, for those kind words. I specifically asked him to say 2 words about me, a Sri Lankan neurologist from Australia, not to mention any one of those things. You can find most of those things if you Google my name. So thank you so much, Pandula. I bring you greetings from very rural Sri Lanka, not from Melbourne, Australia. I came here 3 days back. The night I drove to Bandarawala, where I was born and grew up. Then I spent the next day at Namanukula, where I spent my grade 6. I normally visit those 2 primary schools to talk to the kids. It continued to remain the world's most beautiful place in my mind, despite traveling to about 60 plus countries over the last 19 years. So there are bright kids who still remain going to those public schools. And I'm sure when we are gone, they would continue to do what we do year after year. So you have a wonderful country, and they don't get fed up with all these troublesome periods, and they're there for us too. We have financial burdens too, even in Australia. I'm going to spend next hopefully 25 minutes or so talking about brain health for all. The plan for my talk roughly is going to be around talking about the concept of brain health. I will try and introduce the buzzword IGAP, Intersectoral Global Action Plan, why I would personally like to nominate next 10 years as the decade for brain. I will try and touch upon what is special in this region, Asia, Oceania, And if time permits, we will see our thoughts on what we can do and how we can do this. I have already started my open invitation to you as of now. If I were to ask you to pick the difference, you probably will not. Therefore, I will not ask that question. One side of this slide belongs to a primitive mouse. One side of this slide belongs to well-matured Homo sapiens. Unless you are a molecular biologist, spend your day in and out under an electron microscope, you would not pick the difference. Then how come we become so super smart for better and worse? As I said, having born in a fairly rural area, having absolutely no idea where you would end up in 3-4 decades later, doing things that you always wanted to do, that ability is only available for Homo sapiens. I think the difference is we have this remarkable ability to network, connect, and expand our networks. The Pandula sending me a text message a few months back asking whether I would care to come on board, and then all these things happening in the way that they are happening as of now. So we are the most unique species in this world because of that. It is our brains that makes who we are. It is our ability to connect those neuronal networks and synapses made us who we are. Changing governments, reappointing governments, winning Nobel Prize, killing people, having war, writing most beautiful songs. I had a good time last night with a couple of my co-interns, and we were talking about how brilliant some of those old songs, the beautiful lyrics and other things. They can only be done because of this absolutely amazing, fabulous organ called brain. But we have a problem. At this point of time, brain disorders are the leading cause of disability. 1 in 3 in this audience are having a brain disorder, whether we like it or not. It could be Alzheimer's dementia, it could be Parkinson's disease, it could be multiple sclerosis, it could be migraine, it could be tension type headaches, or it could be an undiagnosed peripheral neuropathy. Therefore, we must care. And to make matters worse, nearly 2/3 of these problems occur in low to middle income countries. So the Asia-Oceania region where we live and practice medicine or any specialty that we practice is home to 64% of the global population. That's 4.72 billion people. And then 1.3 people live in Africa. That's all brown people, not white people. That's well over 80% of the global population. So most of these brain disorders occur in this region. But when we were part of international working groups years back, we realized that the attention for brain had not been very good. It remained the same even today. So we were chatting over a cup of coffee in an international meeting, myself and a neurologist from Karachi, Pakistan. We were plotting the idea how we can change this, how can we make human beings interested in the very organ that made who they are. So I sort of casually told my friend that maybe we should have a day for the brain so that we can celebrate brain, we can talk about it, we can talk about prevention and this and that. So that was in 2012, if I remember correctly, in Morocco. Then in 2013, at another casual meeting over a cup of coffee, we told our president at that time, Professor Vladimir Hachinsky from Canada, that we have this proposal or idea to introduce World Brain Day, perhaps on the day that the World Federation Neurology was born, which was probably 27 years before I was born. So he then asked us to put that to the Council of Delegates, which is National Member Presidents Gathering, and they unanimously voted us in. So 2014, we came up with this idea of our brain, our future. We went globally. 2015, we decided to choose epilepsy. Then 2016, brain health in an aging population. 2017, stroke is a brain attack, prevent it or treat it. 2018, clean air for brain health. Then I took over the committee leadership. I was a founder member in the committee before. In 2019, we changed the game by partnering with another international association. So in 2019, we partnered with International Headache Society, and we did a massive campaign for the first time, creating number of world records by advocating for migraine and better headache care, reaching out to well over 100 million people globally. In 2020, we partnered with Movement Disorder Society, and we did another massive campaign despite the pandemic, using all virtual access points. I think I visited like 76 countries virtually through Zoom and other platforms, and we did a massive campaign on ending Parkinson's disease. Last year, Stop Multiple Sclerosis. This year kind of became unique. We chose Brain Health for All campaign. Why Brain Health for All? I already told you that it is our brains which made us unique compared to other species. If you wanted to know the history, I would encourage you to read Harari's book on Sapiens. I think there is a Sinhalese translation also. It's not 100% correct, the probably 90%, 95% correct historic book, but brilliant work of the evolution of human beings and why we behave in the way that we behave from philosophical point of view. Brain has about 100 billion neurons, and we host about 10 trillion connections. And I already mentioned to you that we are in trouble as 1 in 3 of us are having a brain disorder. If you can't remember anything out of this talk, I want you to go home remembering this. So the points that I'm going to raise in this slide are very important. At this point of time, we have about 111 million people with the impact of a stroke. We have about 50 million people with dementia. Already during last 3 days, I sort of talked to at least 3 or 4 people with cognitive impairment, including my superhero mother, the mild cognitive impairment. So these are problems that are affecting us as of now. Then we also have about 50 million people with epilepsy. I sort of talked to a couple of them over the last couple of days also, not seeing them officially, but conversing with them in Sinhalese language and explaining things in simplistic terms. And then we have about 3 million people with multiple sclerosis and another 399 plus neurological disorders affecting to the lesser extent. So the surprising thing is 90% of the strokes should not have occurred at all, because by now we know that 90% of strokes can be prevented, but we are not good at it. 40% of the dementia could not have occurred at all. Those things could have been prevented. 30% of epilepsy could have been prevented. For Parkinson's disease, multiple sclerosis, migraine, and chronic headache disorders, we have absolutely fantastic pharmacological, nutraceutical, non-pharmacological interventions and treatments. But majority of patients, our patients, can't access them. Majority of these patients would never see a neurologist. Majority of these patients never get a formal diagnosis also. I think it is very important that we should do everything that is possible to prevent brain disorders in the first place. If it is the organ which is making us unique from other species, if it is the organ which helps us to discover solar system, to discover internet, electricity, all these connections, we must protect it, we must preserve it. Yes, we are getting old, yes, we are eventually going to die, but we should die with dignity and we should preserve our brain function as much as possible so that we can contribute to the society while we are living, and we can enjoy what life has to offer to us with preserved brain function. So our work then led to World Health Organization. I shouldn't say the word partner with us. They don't like that word. Perhaps collaborating with us and coming up with, for the first time, a definition for brain health, which I don't personally like, but that's the official definition. I would expect this would change in time to come. Health, you may recall that health is not just absence of disease. WHO themselves told us when we were primary school kids that health is complete social, physical, and psychological well-being. You can then say that there is absolutely no health without brain health. How can you have overall psychological well-being without having brain health? You don't get psychological well-being from your foot or even heart normal. It comes from brain. Therefore, you could see that without brain health, there is no health. But for whatever it's worth, the WHO, the brain health definition is, brain health is the state of brain functioning across cognitive, sensory, social, emotional, behavioral, and motor domain, allowing a person to realize their full potential over the life course. I think what I like about this definition is over the life course. So we wanted to protect brain function across the lifespan from pre-pregnancy times, pregnancy, early childhood, then adolescence, and then growing old. And like my mother and father, when they grow old or when we grow old, we want to preserve brain function as best as we can. So when with this, we came up with this intersectoral global action plan. Because of the time, I wouldn't go into detail. The intersectoral global action plan is basically all national health ministers gathered in late May in Geneva, physically or virtually, and agreed to recognize the brain health and the importance of brain health and come up with an intersectoral global action plan over next 10 years to prevent, preserve, improve access, create essential medicines for brain disorders in each country, including your health minister and my health minister in Australia. They both signed this up. So this is why I said that next 10 years indeed is the decade for brain. So we have political leadership telling us or signed themselves up with a actionable, promised action plan globally across the life course from prevention, treatment, and early access. Intersectoral means we want institutes such as KDU, and health ministry, other universities, industry, the policymakers, and professional societies like Neurology Society, Cardiac Society, Sri Lanka Medical Association, NCD section of ministry, all these sectors partnering with each other to actually get this job done. We all know that politicians are good at signing things up and not doing them. That's why we bought this intersectoral global action plan so that each country actually do the task and then tell us that we have ticked this box. We have done at least one prevention program. We have done at least one essential medicine program for migraine headache disorders, this and that. So if you visit our website, WFN, you could see this the strategic objectives and global targets. I wouldn't bore you to depth by going through them, and they are all available. I reattach this slide to remind you of the importance of brain health. As I said, there's no health without brain health. So for the next couple of minutes, I'm just going to plow through these slides. These are available on our website. You can download them freely and they are not copyrighted. You can use them as you like. We want you to use them and then talk about brain health and take that to community, your students, your teachers, and your colleagues. I put this slide again just to remind yourselves that this region is the business end of the world for everything. 64% of the world live here, not in Sri Lanka, but Asia-Oceania region. This is not a racist comment. This world has more brown people than white people. And I don't see more brown people doing things at global leadership level. I want people to do the best that they can do in the field that they have chosen to do, and then keep doing the best so that we can keep climbing up on the ladder, not to put another thing on your shelter, but to get these things done. I think I put this slide again to remind you prevention is better than cure. I want to use this slide to remind you what can be done by using technology. This is a very simple application that was designed by colleague and friend, Professor Valery Fagin and co. We supported him also. He is a Russian neurologist currently practicing in Auckland. You can download this, the free version for free, stroke riskometer. You can tap on that for 1 or 2 minutes, and it would basically tell you your stroke risk during next 5 years. And then it would also tell you what you can do to prevent your risk of having a stroke. Similar things can be done for most other things. And I encourage you to read what I wrote a few months back during the sort of this year's World Brain Day, again, the free access journal from our society, where we were talking about why we need to promote brain health and talk about brain and the act upon those things now. Again, reminding you of global targets of intersectoral global action plan that your health minister has signed up for. It's intersectoral, so you have a role to play. So the get involved and get to the bandwagon. This is an example from European Academy of Neurology, where they have created an EAN initiative. Since I left Melbourne, the American Academy of Neurology came up with AAN Brain Health Initiative. Perhaps KDU can come up with KDU Brain Health Initiative, so that you can be the first in line in Sri Lanka to the work with this. And the current Sri Lankan Neurology Association president is a very close friend of mine. He's a classmate of your dean. I think they sing together sometimes when they're not doing academic things. So it's a wonderful opportunity for KDU to shine and be a leader in this field and protect Sri Lankan brains, which you desperately need across the board, including your parliament. The awareness is critically important and equally important, the talking about prevention, advocacy, education, and access. It's time to act. I think it's enough that we have been talking and thinking about that. It's like Buddhism or Buddhist philosophy. When I was at Bibilegama Mahavidyalaya, where I spent my year 6, school principal told me that there were 2 boys assaulting each other, and one boy had a broken arm and he was taken to the hospital the day before. So the boy who hit the other boy was in the audience. So I spent 5 minutes of my talk reminding them about the real meaning of Karaniya Metta Sutta in very simple language for a year 8 kid to understand. And I told the boys and girls that next time when I come back to their school, hopefully this would be the last fight that that school has ever had. And I would not want to hear this sort of the gang fight ever again. So the part of the problem is while we have this wonderful teaching of Buddhism or Buddhist philosophy, we are very good at talking, but we don't have that in our mind. I've seen this as a kid. You chant about Maitreya million times, but your heart is full of hatred and anger. So Buddhism doesn't work when it is just for the talk. Buddhism works wonderfully when you embrace that into your heart. And when you are humble, it makes your life so easy. When you behave like a carpet, how can anyone ever bully you? When you're on ground, it is very hard for anybody to push you down. That's the secret of me doing a lot of international things. I really don't care what other people say or how they treat or how they do. I sort of keep myself very humble and keep my humility in the heart and concentrate on the task that I needed to do. Whether people appreciate that or not, again, I couldn't care less about it. It's not an arrogant statement. People say good things about you, people say bad things about you, but you keep unshaken whatever the thing coming on your way. So be a Buddhist, a practical Buddhist. I think the same thing with global, the brain health. We can keep talking about things, but unless we do things and unless we embrace them at a practical level, things wouldn't happen. But we are in a crisis now, so we have to act. If we don't act, we fail. There would be another species running this world rather than Homo sapiens if the current trend continue to occur for another 2 or 3 generations. So get involved to make a difference. These are some of our work on World Brain Day. I think I talked about awareness, prevention, advocacy is the talking or working on behalf of someone else's interests. Education is critically important. You already heard that I am from fairly rural, the Sri Lanka. I absolutely had no idea that I could end up in medical school when I selected to do biology stream. This is not a lie. That was how things were in 1985 in Bandarawela. And the only reason that I chose biology is I like the pattern and I didn't particularly enjoy mathematics. I like mathematical patterns also, but I like biological patterns more than mathematics. So that's the only reason that I decided to choose biology stream. But you can see that once you educate a kid, if you educate that kid with good values and good things, that kid, whether it is he or she or them or non-he, non-she, to cover all bases, they would go and do great things to the humanity wherever they are with global impact. That's why we must invest on education. Access is also very, very important. The Sri Lankan health system is one of the best in the world. Wherever you are, you can access some sort of care through primary to tertiary across the country. There aren't many countries with that sort of access, including Australia. The Sri Lankan patients can access a cardiologist or neurologist much more faster than in Australia or UK or USA. Again, time to act. Let's get together and promote better brain health globally. And with that, I would stop the talk, and I'm happy to take a couple of questions if needed. Thank you so much for the wonderful opportunity. It's an honor and privilege to come to this place. I had been here multiple times before when late Professor Weerasooriya was the dean. He was one of our favorite teachers as young kids. I almost felt that he was a demonstrator because he was the most closest to us. He sang more songs than us. He probably drank more alcohol than most of the boys also in some of those parties at that time. We had a good time. So every time when he asked me to come in, I made it to occur, honoring how kindly he treated us as first-year students, having absolutely no clue where we were heading at that time. So reminding his great legacy and thanking Pandula and Namal and others for having me here. Despite the hectic day ahead of me, I got 3 more talks to be done once this is done at SLMA and Peradeniya. And thank you for your presence also.
Okay, thank you for that very clear, thought-provoking, excellent presentation on brain health. As a Peradeniya product, I feel so proud of you, Professor Wijeratne. Now, as he kindly agreed, now we have 5 minutes time for questions.
Now, all over the world, there are sporadic reports coming, especially from USA, regarding mindfulness and meditation. And it is so now inculcated in the minds of the people, they every day talk about it. Has become a household word in certain parts of the world, mindfulness. Now, it has been shown that meditation will help to get rid of all these illnesses if you really adhere to the principles. Is there a scientific basis? Because you have been a great scientist. Is there a scientific basis to prove that meditation will prevent these illnesses? And have you got any scientific papers to present?
That is a great question. Mindfulness, the absolutely works. There is a lot of scientific evidence how it might work. In fact, there is a whole subspecialty. It's not directly talking about mindfulness. It's called psychoneuroimmunology. So the way that it works is, I think, I'm not saying that mindfulness would fix everything, but if you are mindfulness and if you practice mindfulness very well, it helps your immune system and your other physiological systems to do its job better. If you look at psychoneuroimmunology literature, which is actually a significant chunk of my thesis in my PhD, the onset of post-stroke recovery trajectory path, it shows that when you are under stress, whether it is a physical stress or psychological stress, it establishes negative networks in your immune system and physiological pathways to cause pathology. That's one thing to say. The second thing to comment is the in happiness literature. There is functional MRI evidence to suggest that when you do fMRIs on deep meditating monks, they have found that significant higher levels of dopamine presence in their brain. I think the way that it works is the preventative approach work with overall emphasis. But mindfulness has a great role in that armamentarium.
Thank you very much.
Answer the question.
So I will just repeat the question. Like I was wondering whether this the aging, natural aging related to wear and tear in the brain is related to the adverse effects of the brain and lead into neurological disorders, and if there are anything that we can do to slow down the process.
Absolutely. So that's another great question. So the question is in simplistic terms, we lose our brain function as we get older. Is there a way to preserve it, and what sort of tips I have to give to protect our brain function as we get older? So the answer is correct. So the brain, as I said, has about 100 billion neurons and about 10 trillion the synapses that does all what we do, from thinking, falling in love, singing, doing this sort of talk, asking that sort of question, and you patiently listening, etc. But we lose brain function as we grow older. I probably had more preserved brain cells and synapses 10 years ago than what I have now. So the things that preserve brain function are good food, that's an overall healthy diet that Namal and other colleagues had been talking about, and endocrinologists talking about exactly the same thing. Good sleep. Good sleep in the sense sleeping too much is bad for the brain, and sleeping too little is also bad for the brain. I sleep very little, otherwise I wouldn't have done all these things. So that probably would take me away from this planet a few years earlier than my natural lifespan. So someone should sleep a bit better than me, at least 6.5 hours. Anything more than 7 hours had been found to be not good for the brain function. The reason behind this is brain doesn't have a lymphatic system like other organs. It is estimated that brain get rid of all the gunk during sleep. So if you don't sleep, you keep remaining those gunk, and that that raise the risk of brain disorders. Third thing is good fluid and good air. Good fluid doesn't come in colored bottles or non-colored alcohol bottles. They come in the context of water. And then not smoking and breathing clean air. That helps also. Few other tips. As we get older, if you realize that I can't remember things as I used to be, like my mother, it's a sort of a nice reminder that now you need to challenge your brain. You still have a lot of untapped resources in the brain. So you start reading non-fiction books. You start doing things that you didn't like to do before. You start learning something new. Say, for an example, recently I started how to play a guitar. I don't have any cognitive issues, but it's a challenge for me. I never learned all those codes or practice those things before. So it basically stimulates different part of my brain. And as I get older, there's no benefit for me to read about brain and brain related things. That's my cup of tea. I should probably read about something else. I hate politics, so I might start reading about politics or economy or something like that. Then traveling to different places, places that you haven't seen, that's a good thing. Looking at your old photo albums, your wedding photos, or when your children were born, or your school days, that helps the aging brain also. And then getting involved. I think part of the problem for my mom is during last 2 years, because we blocked her from going out to the temple or going out to visit sisters and others. While dad break the rule, mom didn't. So that probably wouldn't have helped her. So being able to socialize and getting socially connected help also. Singing, dancing, cycling, all those things help also. I think those are some tips that I can think of. Then there are a whole lot of brain boosting nutraceuticals and other things. I don't think that there is much evidence for that. If you eat a good diet, I don't think you need to add any extra vitamins to protect them. Although this is not proven scientifically, I strongly believe that being nice to other human beings is a good thing, and being a good person is also a good thing. And mindfulness and being truly mindful at a practical level and being kindful also helps also. The latter few things have not been proven scientifically. They are my own takes on this. And the last thing is, even if you have moderate to severe dementia or diagnosis, one should not give up. You should keep learning, keep exercising, keep being in the green. The ability to learn things are unimaginable. In my home garden in Sri Lanka, in rural Bandarwala, when my son became interested in birds, he taught me that 14 endemic birds visit my parents' garden on a daily basis. And he told me that you shouldn't say that that's a little yellow bird, that's a little pink bird. They all have a species name and the family name, and you should call them with respect. So when you start learning them, it challenges your brain also. So the opportunities to learn are everywhere around us. So all those things help aging brain.
Thank you so much, Prof. Wijeratne.
If you have time for one more question about
That will be the last
regenerative
question.
medicine and boosting the brain's natural ability to regenerate and then repair the damages that are happening. Could you kindly enlighten us a little bit about where the state of the art research is heading in terms of repairing glial scars or plaques? And then is there a role for brain related stem cell research in your area of expertise, and how it is likely to transform in the next 5 to 10 years?
Pandula, that is a great question also. A lot of work had been going about regenerating brain, and a lot of money being thrown at this field also. They are still not at highly translational levels. If I were to draw parallels between cardiology and neurology, though, I always tell that we are 10 years behind our cardiology colleagues, or probably even 15 years. They thrombolize heart attacks probably 30 years before us. They start stenting and cleaning blood vessels 20 years before us. They start stenting the 10, 15 years before us also. Our group was one of the pioneer groups of bringing the interventional neurology to the stroke treatment. In fact, our papers in NEJM were the sort of highest. But there seems to be some the differences also. The intracranial stenting cause more harm than benefits. And the thrombectomy, we still have proven benefits for the frontal blood vessels, not for the back blood vessels, but we still clean them though, and they get better outcome, including Professor Ratnatunga, as you know, that I was also involved remotely a long time ago. He had the interventional treatment for basilar artery. He's doing very well now. So to summary, a lot of work had gone to regenerative the neurology. what you and me learn as medical students that once brain cells gone, they would never come back. That's not true. The brain has remarkable ability, what is known as neuroplasticity. That's why one should never give up, irrespective of the state of the disorder that you have. Preserve, promote, and use what you have. Regenerating using stem cells and other things, not proven at this point of time. If you have a patient, they must only be treated in a dedicated research center as part of a trial participant, not as a payee. With regard to intervention, we are coming behind you lot, but we are still probably a decade or so behind. We can clean blood vessels with the thrombolysis with a couple of thrombolytics, and we can reperfuse certain blood vessels, but not all. Intracranial stenting is no-go zone, that's a sort of a summary version of that.
Okay, thank you so much again for that excellent presentation. Let us start the free papers. The first paper is on sexual dimorphism in Sri Lankan saw-scale viper based on the mensural and Pholidosis characters.
Good morning, madam. Shall I start the presentation?
So, ladies and gentlemen, this moment is to appreciate the guest speaker who added color and knowledge for our today's agenda. So, let me cordially invite the Vice Chancellor of General Sir John Kotelawala Defence University, Major General MPP RIS, RWP, RSP, VSV, USP, NDC, PSC.
Accompanied by the Dean of the Faculty of Medicine, Commodore Professor R.A.N.K. Wijeratne, to hand over the token of appreciation to our special guest speaker, Professor Tissa Wijeratne.
Thank you, sir. So let me invite our chairpersons to continue on with the technical session. Thank you.
The first paper is on sexual dimorphism in Sri Lankan saw-scale viper based on the mensural and Pholidosis characters. It's by A. Murugananthan, A. Gnanathasan, and T. Kumanan. A. Murugananthan will present the paper online.
Thank you, madam. Good morning to you all. My presentation is on the sexual dimorphism in Sri Lankan saw-scale viper based on the mensural and Pholidosis characters. Introduction. Saw-scale viper of the genus Erkis are the member of Viperidae family found in the tropical world, which is extending from the West Africa to India up to Sri Lanka. In Sri Lanka, it is distributed only in the dry and sandy coastal areas of northwestern, northern, and in the eastern provinces. In northern province, it is widely distributed in the districts of Jaffna, Kilinochchi, Mullaitivu, Mannar, and contributing more than 50% of the snake bites in this region. Although the taxonomy of Erkis has been revised for decades, still it is very complicated and poorly understood because of its highly diverse nature. As per the recent taxonomical classification, the genus Erkis is classified under 4 major clades. Accordingly, the Erkis oscillators group, which is distributed in the Western African area. And the second one, the Erkis pyramidum group, which is distributed in the Western and Eastern Africa up to Somalia. And the third one, the Erkis coloroides group, which is distributed mainly in the Middle East area. And finally, the Erkis carinatus group, which is distributed in the Southwestern Asia, mainly in India, Oman, United Arab Emirates, Pakistan, and Sri Lanka. The Asian group of Erkis carinatus reported to be including 4 subspecies. Erkis carinatus, which is reported from the peninsular India, and Erkis carinatus astole from the Astole Island, Pakistan, and Erkis carinatus shokreki from Afghanistan, Pakistan, Northern India, Iran, Iraq, Oman, and United Arab Emirates. And the Erkis carinatus singularis, which is reported only from Sri Lanka in 1951 by Dharaniya Gala. So therefore, there is a need to study the detailed taxonomy of Sri Lankan saw-scale viper because of the following reasons. The current taxonomy of Sri Lankan saw-scale viper reported by Dharaniya Gala in 1951 using only 8 museum specimens collected from Chavacheri, which is located in the Jaffna district of the northern Sri Lanka. And there is no studies conducted in this regard or regarding the taxonomy of Sri Lankan saw-scale viper thereafter. From the clinical point of view, Sri Lankan soft-scale viper appears to be causing very minimal fatality when compared with the rest of the or its counterparts. Further, the recent proteomic study on Sri Lankan soft-scale viper venom showing a great variation in the venom composition when compared with its counterpart in India. Therefore, considering the fact that the antivenom raised against one venom being ineffective in neutralizing another venom, a clear identification of the taxonomy of Sri Lankan soft-scale viper is very important, because still we are using that antivenom imported from India, which is not prepared against by using the Sri Lankan soft-scale viper. So therefore, the present study was designed to study the morphometric or the morphometric characters of Sri Lankan soft-scale viper in detail using the specimens collected from the multiple localities of northern Sri Lanka, and also to analyze the dimorphism, sexual dimorphism in Sri Lankan soft-scale viper based on the mensural and meristic characters. So materials and method, a total number of 30 adult specimens were collected from the different localities as per the map which I have shown here. During the period between 2019 to 2091. Study procedure, the adult specimens without any damage, because having a physical damage in the specimens will be very difficult to do the detailed morphometric analysis. So therefore, only the adult specimens without any physical damage was selected for this study, and sexing was done by separate, and the male and the females were separated. The mensural, meristic, and the color pattern of the selected specimens were recorded and analyzed descriptively. Sexual dimorphism was estimated based on the sexual dimorphism index as reported previously. The relationship of sex with morphometric characters were analyzed using the Wilcoxon statistical test. Sexing was done by examining the hemipenis under the dissection microscope based on the presence or absence of hemipenis by eversion, or by putting a small incision, a small median longitudinal incision in the region of the first subcaudal scale. Measuring the mensural and the meristic characters. Mensural characters were assessed using a tape and a standard vernier calipers. Snot vein length was measured by using a piece of string. Counting and measuring of all small items were conducted or performed under a dissection microscope. Snot vein length and the tail length were measured to the nearest of 1 millimeter, and the other mensural characters were measured to the nearest of 0.1 millimeter. These are the mensural characters studied in detail from all the specimens individually. Among them, as far as the present study is concerned, the rostrum anal length, tail length, and head length are the most important most important measurements which we have taken for the polymorphism analysis. These are the meristic mensural characters we have studied in detail from all the specimens individually, and among them, the dorsal scales, ventral scales, and subcaudal scales are the most important one for the dimorphism analysis. So these are the some other meristic characters we also studied, although they are not contributed or analyzed in the subsequent analysis. These are very minute parameters we have taken into the study. Color pattern. In addition to the mensural and the meristic characters, we also studied the variation in the following color pattern. Accordingly, the dorsal color, ventral color, head and the nape pattern, number of dorsal patches, number of supralabial pigmented, and number of infralabial pigmented also recorded separately. Statistical data analysis. Before doing all the other statistical analysis, the homogeneity of the variants were tested by Levene's test to make sure that all the variants were distributed uniformly. Morphometric and the meristic characters of original data were presented using descriptive statistics. Body measurements found to be diagnostics are given as the percentage of the rostrum anal length or the head length for the convenience of the direct comparison. The relationship of the sex with the mensural characters were determined by Wilcoxon test. The significance level in all the tests were equal or less than 0.05. This is the summary of some selected meristic characters we have studied. I didn't include all the details. So this is the summary of the most important meristic characters that we have studied. And in this table, I have also highlighted the taxonomical information of Sri Lankan source scale viper, already reported by the previous workers. So it is very clearly visible that none of the previous reporting describing the difference between the males and females and reporting was purely based on few museum specimens. So this is the summary of the mensural characters that we have studied, which also comparing the mensural characters between the male and female individual. The sexual dimorphism was estimated by sexual dimorphism index as per the following formula. Accordingly, the mean rostrum anal length of the larger sex is divided by the mean rostrum anal length of the smaller sex. So we got a positive value of 1.16 in the study, confirming that the females are larger than males. Statistical analysis of the other mensural and the meristic characters by Wilcoxon test revealed that the meristic triads appears to be less variable between the male and female, except the ventral and subcaudal scales. Females have a higher number of ventral scales than males, whereas the males have a greater number of subcaudal scales than female. All the other studied mensural and the meristic characters showed a complete blending between male and female. We also conducted the regression analysis to identify the correlation between the tail length and the rostrum anal length among the male and female. And we identified that the tail length is influenced both by the rostrum anal length and the sex, with a good approximation between the sexes. We also studied the variation in the color pattern or following color pattern and among all these specimens. Although we have identified a lot of variations in the color pattern among the individual specimens, it was not associated with the sex of the specimen. Conclusion, we observed that the adult female of Sri Lankan source scale viper have a larger body size than adult female. The higher body size and the number of ventral scales in female can be a reflective of an optimization of the reproductive potential, because the female needs a higher body volume to produce higher number of eggs or larger size of egg. A similar observation was reported in several other species of snakes as well. However, the larger body size of male snakes can be considered as the behavior of competition for territory for female during the reproductive period. We found a higher value of sexual dimorphism of more than 0.05 indicates that the absence of territorial behavior among the Sri Lankan, among the males in Sri Lankan source scale viper. These are some of my key references which I have used in this study. I would like to thank the following individuals for their valuable contribution to complete this project successfully. I would also like to convey my sincere thanks to the National Research Council Sri Lanka for providing the financial support for this project. Thank you.
Okay, now the paper is open for discussion. Any questions?
In the absence of any questions from the audience, I would like to ask one question from the presenter. You mentioned that during this study, you had to place an incision, some form of incision on the animal. My question is, did they suffer any pain as a result of this? And was there any permanent harm caused to the animals because of this?
Yes, sir. The most of the specimens that we have collected was not alive, so the dead specimens, and even the live specimens, because we cannot do the detailed morphological analysis of the meristic and the other mensural characters with that alive specimen. So we have to freeze the specimens, and we got the ethical clearance for that from the ethical review committee of the Faculty of Science, University of Jaffna, to do that procedure, which was the accepted procedure to do the morphometric analysis in detail. So we didn't do the incision procedure in the live specimens.
Okay, thank you, Dr. Murugananthan. Let us
Thank you,
move for
madam.
the second presentation.
There's one question asking about the utility of this data. Is it that the female source scale viper, has more venom, or is there a practical application, in identifying whether it's a female or a male based on these characteristics? What's your what's the take home, for a wider medical fraternity?
Yes, thank you, sir. Actually, the taxonomy of Sri Lankan soft-scale viper, the studying, because all over the world, the soft-scale viper taxonomy is one of the very complicated, and every year there are a lot of revisions coming in. And according to the current publications derived from the soft-scale viper populated areas, there is a great variation in the venom composition, even within the similar species. Even a recent studies conducted in India identified that there was a clear variation in the venom composition, even within the soft-scale viper present in India. Therefore, identification of the detailed identification of the detailed taxonomy of the soft-scale viper is very important as far as the venom preparation, anti-venom preparation is concerned. And this sexual dimorphism is part of the taxonomic studies that we have conducted, and ultimately end up with to find whether the Sri Lankan soft-scale viper is a similar species which is already reported in the other part of the country, or is it a different species? So if it is a different species, then we have to think about developing our own antivenom. Thank you, sir.
Thank you. So we come to the second pre-paper today, and that is assessment of knowledge and clinical skills for minimum image set in focus for EFAST and lung scan among Sri Lankan emergency medicine trainees. Focus means point of care ultrasound, and a technique that is becoming more popular. And we will take the questions after the paper. The paper will be presented by D.S. Arachigi.
Thank you very much, sir. So how do we do the focus? How others do it differently? How to do it as per the international standards? So that is the million-dollar questions which fascinate me to do this research. I think this is an amazing time to talk about the focus in this COVID era with the limitation of the resources. So my abstract presentation include the content, justification, objectives, methodology, ethical clearance, result, and conclusion. Let's talk about how focus transformed over the time. Focus was born in Europe in 1970s in emergency room. Due to the unreliability of the physical examination and clinical findings of the trauma, especially abdominal trauma, it was really hard to accurately assess the findings. So that time, only way of assessing the pre-fluid was diagnostic peritoneal lavage. So it is traumatic and also very invasive procedure. This make appropriate target for the development of the focus. Initially, this was named as defined as echographs because of the because we use ultrasound to do echocardiograms. However, with the time, with the development of the technique and also with the development of the protocols, this assessment was renamed as FAST, and later it was renamed as EFAST. Decade later, in 1980s, initially, that initial artifacts of the lung was described again in Europe. However, in 1990s, Professor Daniel Lichtenstein, he's one of the prestigious critical care physicians. He's the one who has formulated a protocol called Blue Protocol to diagnose lung ultrasound. How about the 21st century? 21st century is, that is a matter of practicing. So now already those protocols were formulated, and now it's a matter of accuracy, how to practice in proper way. So all the prestigious colleges has formulated their own pathway for conducting and also regulating ultrasound scan, bedside ultrasound scan. So this is American College of Emergency Physicians. They're having their own pathway. So, however, there's a similarity in between all the curriculums and also assessment protocols. So this is called the minimum image concept. So where that you take certain number of standard images and then you interpret. So by doing that, you can minimize the false negative rate, and also you can assure the safety of the patients. How about the Sri Lanka? So Sri Lankan Society of Critical Care and Emergency Medicine Society was formulated in 2002, and they introduced a ultrasound skill program in 2010. So it's called the WIN Focus initially. Emergency medicine actually was established in Sri Lanka nearly 50 years behind the rest of the developed world. We are having some sort of assessment within our exams. However, we do not have separate assessment like USA or UK or other countries. I think this is common for all the specialties. WinFocus is one of the most popular core skill module in Southeast Asia due to the availability and also due to the affordability of the program. It's a 2-day program. So this was initially in 2010, and also Board of Study Emergency Medicine also recommend this program as a prerequisite for the MD examination. My objectives was to describe the training and knowledge of minimum image set required by the emergency and critical care protocols among the trainees in emergency medicine in Sri Lanka, and also to determine the standard of locally available basic skill ultrasound courses. This descriptive cross-sectional study, which was done in PGIM among the emergency medicine training for 1 month duration, and sample size was 97. And this includes all the emergency medicine trainees who has at least complete 3 months of emergency medicine training. And also I have excluded unsuccessful candidates at part 2 examination. Data was collected by self-administered case-based online questionnaire, and also assessed by the SPSS 20 software. Ethical approval was taken from the Ethics Review Committee, National Hospital, Sri Lanka, and also confidentiality was maintained during the research and after the research. So let's talk about the result. So this shows the demographic details of the study population. 31% of the respondents from the SR with foreign training capacities. That means that they're having some sort of good knowledge. And 7% is from the first year trainees. And interestingly, most of the 23% of the trainees has 5-year experience in bedside ultrasound scan, whereas the 26% have at least 1 year experience in bedside ultrasound scan. This is about the source of the learning ultrasound scan. 63 individuals has undergone some sort of a repeated training, and out of that, 61 has done WinFocus ultrasound program. Interestingly, only 2% has learned ultrasound in conventional ways. So that is from the textbooks. This is about the credentials and accreditation to perform bedside ultrasound scan. 63% aware about the credentials. However, only 15.6 has had some sort of accreditation to perform bedside ultrasound scan. 37.1% aware about the minimal image or protocolled concept. However, only 20% have some sort of awareness about the validity of this concept. So this shows the distribution of the marks. So left-hand side, you can see the EFAST responses, and the right-hand side, you can see the lung ultrasound responses. And this clearly depicts the knowledge distribution. As per the graph, his mean was 7.68 and standard deviation was 3.016. And according to this graph, 75% have unfortunately poor knowledge and 25% have good knowledge about this concept, protocol ultrasound concept. This slide shows the association between the various variables. So this includes the pre-MD ultrasound experience, source of knowledge, whether it's from the repeated course or not, and also MD emergency medicine program, and their awareness about the minimal image concept and its validity. Unfortunately, there was no any association, significant association between above variables and the good knowledge. This slide shows the association between the specific course. So out of 97 individuals, 61 had undergone repeated WinFocus as their main ultrasound skill course. However, there's no association between the good knowledge and the WinFocus ultrasound program with regards to the minimum image concept. So my conclusion was the study demonstrated absent clear relationship between the level of the training, seniority, and the knowledge and clinical skills. Moreover, there's no relationship between the knowledge and the repeated ultrasound course. Oral knowledge about the protocol approach among there's a poor knowledge about among the about protocol approach pathway among the participants. It is recommended to improve the knowledge of minimal image concept after the EFAST and lung ultrasound among the Sri Lankan emergency medicine training, formulating a pathway similar to the American College of Emergency Physician or Australian College of Emergency Physicians in order to increase the accuracy of bedside ultrasound scan. So there are some limitations in this study. So oral knowledge cannot be assessed with the self-administered questionnaire, and also application of the knowledge, demonstration of the technical skills and integration in the clinical practice is very important here that I have not completely assessed that, and also participants were not assessed in their clinical settings. So that is one of the limitation in this study. So those are my references, and I would like to thank KDU. And also, I would like to thank my supervisor, Dr. Landron, and also my advisor, Kylie Barker, for supporting for this research. Thank you so much.
Thank you. The paper is now open for discussion. In the absence of questions from the audience, I would like to ask the speaker one or make a comment. This technique of focus or point of care ultrasound is now being used extensively, even by intern medical officers. They somehow gather the information, learn the technique, and they use it to assess the leaking stage of the onset of dengue fever, which is a very common infection now. So it would be useful, I think, if we could offer some training, not only to the doctors who are doing emergency medicine, but even to the internees who start way before or just before they start their work, because they use it very extensively to assess the onset of the critical phase in the management of dengue fever.
Yes, now the problem in Sri Lanka is lack of a standard course. So I think we have introduced one ultrasound course, that is a skill module through our college. However, the key, that skill module is not enough to that increase the standard of the bedside ultrasound scan. So there should be some sort of pathway like logbook assessment pathway, and then recording cases and interpreting it, and also supervised by some sort of a supervisor in order to increase the accuracy of the bedside assessment. Otherwise, it can negatively impact the safety of the patients.
In your opinion, how long, how many days would it be necessary to impart the basic minimal knowledge for a medical doctor to do the focus? Yeah.
Yes, sir. So usually internationally, and also from our college as well. So individual has to complete physical module initially. After that, they can enroll into the clinical skill module. So there are various type of courses: 1-day courses, 2-day courses, 3-day or 4-day courses. I guess standard is 4-day clinical skill course. After that, they need to collect ultrasound scan, and they need to record it in a certain way, and then should be reviewed by a supervisor. I think probably we can let them perform ultrasound scan after core skill course.
Thank you. Are there any questions from the audience? Okay, in the absence of any further questions, I thank the speaker, and we will get on to the next paper.
Thank you, sir.
The next paper is on a topic that is guaranteed to create interest, that is erectile dysfunction. And it is the paper is named as Ayurveda Intervention of the Management of Dvavabhanga, WSR Erectile Dysfunction, Systematic Review. And I call upon the presenter to present the paper. The paper will be presented by Dr. M.S. Sanjeevani Pereira.
Good morning, Chair and distinguished guest. I'm Dr. Sanjeevani Pereira. Today I'm going to present Ayurveda management of Dvajabhanga with a special reference to erectile dysfunction, a systematic review. This is a presentation outline. Actually, Ayurveda classics has been mentioned there main three pillars. We call Triyupastamba. Is one of these is the healthy sex and material rights. So, in the system of Ayurveda, the inability to activity of the sexual activity we called as Dijabanga. It can be correlated with the erectile dysfunction in modern medicine. So as you know, the prevalence, the approximately 52% men are experiencing any stage of ED. It can be minimal or moderate or the complete, and up to 150 million worldwide are estimated in affected in ED. So actually this is why this important is this study, because this is a burden problem. However, many treatment modalities has been mentioned in Ayurveda texts, but some of the Ayurveda researchers has been used treatment modalities and conducted scientific researches, but so far not have been done any systematic review for find out the scientifically proved cost-effective treatment protocol for the ED. So actually, objective is this study was to comply Ayurveda intervention in the management of ED and to analyze the Ayurveda intervention of the management of ED. A recent question was generated by using PICO model, whether Ayurveda intervention is effective in the management of ED. Coming to methodology, actually use the guideline of the systematic review of intervention and the reported guideline of the PRISMA guideline. The eligible criteria of this study, according to the study design, literature review without Ayurveda intervention, animal research studied and laboratory research were excluded. Then below 18 years and above 70 years, patients with multiple chronic disease were excluded in this study. According to the intervention, acupuncture treatment and Chinese medicine, ED management with the allopathic drug were excluded in this study. Other Panchakarma means a unique purification treatment in Ayurveda and Ayurveda procedural intervention and aphrodisiac drugs were used for this study. These are the information resources, and this is the research strategies. You know, this PRISMA charts. And coming to assessment criteria, actually subjective parameters has been assessed according to the International Index of the Erectile Dysfunction, IIEF 15 and IIEF 5, or modification objective parameter based on the Ayurveda classics. Actually, IIEF 15 is the 15 questions. These are the questions. These questions divided into 5 domains is IIEF 5, erectile function, orgasmic function, sexual desire, interpersonal satisfactions, and overall satisfactions like that. So these are the modification subjective parameters. And as objective parameters, seminal fluid analysis was done before and after the treatment. Coming to result, after selection process, 23 articles were reviewed. Among them, 19 clinical studies were found, and rest of the 14 review articles related to intervention. According to the study design, there was 2 studies, randomized comparative study, while randomized placebo study also 2. And in this study group, one of the single arm clinical trial and the case study also included. This is the clinical intervention of these studies. Actually here mentioned in the Panchakarma treatment, aphrodisiac drugs and external application, Ayurveda procedural intervention, and placebos. In these studies, one study was psychogenic ED, and while 2 studies are ED with diabetic mellitus, and the 5 studies were ED with without diabetic mellitus. As a subjective parameters, IIF-5 has been used as an assessment criteria for 5 studies, and modification subject parameters were used for 3 studies. This is the overall results in study 1, study 6, study 8, and study 9. Actually here, Panchakarma treatment with the aparadoxic drug group is shown the best result. In study 8, it's a single arm study. The Kapikachu Chorna, we called it the Sinhala name Vandurume. So it's used as a powder. It's also shown a best result. Then coming to this is a graph. This comes to study 4. Actually, it is a randomized placebo-controlled trial. Here, the ficus religiosa, aswatha powder. It is this result shows a better improvement in the patient with ED with the diabetic mellitus than the non-diabetic patients. Here, in this study was based on the psychogenic ED. Here, use the ashwagandha, we call it Withania somnifera powders used. Actually, here it has not effective in the management of the psychogenic erectile dysfunction when compared with the placebo. This is a study 2 also shown the results of the Panchakarma treatment is the best. And here also study 3, it's a randomized placebo control trial. Here used the aparadoxic formula. Actually, best results was found of that group. Study 5, actually here also use Panchakarma treatment with the aparadoxic drug. Here, the best results was found for that combination. Overall objective parameters, the actually semen volume and sperm count is increased for the Panchakarma with aparadoxic treatment group, as well as the single powder use of Kapikachu Churna. Coming to the intervention review article, also that result revealed that the Panchakarma is the best for the line of treatment of ED, and 16 medicinal plants which are having an aparadoxic effect they mentioned in this those articles. So coming to discussion, actually Panchakarma is the best effect for the ED management of the ED, as well as the single application of Kapikachu Churna shows the best improvement on sexual desire. And also ficus religiosa aswatha is also the anti-diabetic action. So it is see the most results of the diabetic with ED patients. So this is a discussion of review article. It also mentioned the Panchakarma treatment is the best general line of treatment of ED. Actually, we can conclude that this Panchakarma treatment with aparadoxic treatment is a highly significant and highly effective for the management of ED and also these are the medicinal plant as aparadoxic treatment for erectile dysfunction. This is a Kapikachu, Shatavari means Hatavari. The ashwagandha is Withania somnifera plays a major role for the erectile dysfunction. These are the references, and thank you very much for your kind attention.
Thank you. The paper is open for discussion.
It has been sort of a well-known fact that this psychogenic erectile dysfunction occupies a large component.
Yes.
And were you able to identify that group before starting various decoctions and all that? Was it an easy task or a sort of a difficult task?
Yes, sir. Actually, that is study I will show you. Actually, this study was done psychogenic ED because here they mentioned psychogenic ED was diagnosed by DSM-IV-TR criteria. So according to that criteria, they selected the groups.
Thank you for the presentation. You had used the semen volume as an objective criterion of assessing erectile dysfunction.
Mm.
Is there a connection between erectile dysfunction and the semen volume?
No, so as an objective criteria, the study was done a seminal fluid analysis.
But your primary objective of the intervention is to find out whether a particular intervention has a beneficial effect on erectile dysfunction or not. Am I right?
Yes.
So in that case, if it is erectile dysfunction that you are assessing, the effect of erectile dysfunction as a result of the intervention, using the semen volume as an objective criterion of assessing the efficacy of this intervention, is it scientifically valid or not? That's my question. Thank you.
So actually, it's actually objective parameters. We mainly focus here. These studies are objective parameters because IIEF 5, we can clearly assess to that parameter. We can use that parameters. We can clearly assess to the erectile dysfunction. When we are normally not using for the directly objective parameter, directly semen fluid analysis for only the semen point analysis, we can't assess the erectile dysfunction.
Make that to the WHO or anything like that,
Yes.
recognize the filter institute.
Yes, sir, we need to actually, we are planning to do the collaborative research for this purpose. This is a systematic review. Actually, that so far, no, that much scientific research have done, but we have so many formula and so many single plants and drugs. We are planning to do this. Thank you so much.
Right, so we have come to the end of today's pre-paper sessions. And now we have to hand over the certificates to the presenters.
So, ladies and gentlemen, we have now come to the end of the first technical session, which was indeed very interesting.
On behalf of the organizing committee, we would like to thank the Professor Mirani Weerasooriya and Dr. Janaka Munasinghe for sharing this wonderful session.
Dear esteemed academics, we have been listening to eminent speakers, deliberating around medicine and related research since morning.
So all these valuable insights gave us a new perspective that one should adopt while examining these scenarios.
So moving on, we are about to award the certificates of participation for the presenters this morning. And let me cordially invite the chairpersons of today's session, Professor Mirani Weerasooriya and Dr. Janaka Munasinghe, to hand over the certificates.
So as we head our first and second presentations through the online platform, let me call upon the presenter of our third presentation, Ms. M.S.S. Pereira, to receive her certificate.
Sir and madam, please kindly remain on stage. So it's time to appreciate our judges this morning. Let me invite Dr. Iranti Kumarasinghe to receive her certificate. Dr. Saman Pushpakumara. And Dr. Dilusha Lamavadusuriya.
Appreciation is a wonderful thing, and they will be the memories that we remember tomorrow.
So, ladies and gentlemen, now let me call upon the Dean of the Faculty of Medicine of General Sir John Kotelawala Defence University, Air Commodore Professor R.A.N.K. Wijeratne, to hand over the token of appreciation to our guest speakers, to our distinguished chairpersons of this technical session.
And now let me call upon Professor Mirani Weerasooriya and Dr. Janaka Munasinghe to receive their souvenirs.
Thank you, sir. Thank you, madam. With this, we conclude the first technical session of the 15th International Research Conference of General Sir John Kotelawala Defence University. And now let's move on to a short break with refreshments.
And our next technical session will commence in a few minutes. Thank you.